All right, so I'm going to be talking about the spinal cord syndromes. So this is one of those things that might feel complicated, but if you can understand how, like where and where are the different tracks of the spinal cord are located, and I have put a diagram. I'm going to try to use this diagram to explain pretty much all the cord syndromes. It's going to be really easy. Like if you can correlate each the diagram properly with the tracks that are involved and what these tracks function for, then it's quite a fairly easy work, interpreting the cord syndromes. So let's get started. So the first one, a complete cord transaction. So a complete cord syndrome. So this is where there is complete cord, the cause is a complete cord traction, transverse myelitis, so something like that. So what happens is, because the entire spinal cord or that level is affected, so you will see all motor as well as sensory being affected, and an upper motor neuron-like presentation below the level. You're going to see pretty much upper motor neuron type lesions or presentations for all of the pretty much cord syndrome except cauda equina and conus medullaris. Other than that, pretty much the remaining, which is the anterior cord, posterior cord, central cord, Brown-Sequard, so all these things are going to have an upper motor neuron signs below the level. A lower motor neuron sign can be there at the level, but usually below is an upper motor neuron, with conus medullaris having mixed. Cauda equina would have low motor neuron. Yeah. So now come to the first. We talked about the complete cord transaction and how the entire spinal cord is affected. So the motor as well as spinal tracts are completely affected. And just since we're just starting, I might as well just talk about some of the tracks. So anteriorly you have the spinothalamic tracks, which will cross higher up. So when you say look at one side, it's actually the opposite side. And usually when we're talking about cord syndromes, we are just pretty much saying that it's bilateral in general terms, unless it's Brown-Sequard, which is specific for hemisection of the cord. So maybe some kind of stab injury or something like that if it's in Brown-Sequard. So otherwise we are usually looking at things bilaterally. So now come to the tracks. So we have the pain and temperature, usually the lateral, with anterior being for the crude touch. Then the posteriorly on the spinal cord, you will see the dorsal column, which is for proprioception, vibration, and fine touch. Then just somewhere around the middle, you will see some corticospinal tracts. These are your motor tracks, so you can really correlate the motor symptoms with these tracks. So pretty much that's all what you will see, and you can see I have drawn a line which says A2/3, which is basically the anterior 2/3 of which is the spinal cord. So I put that marker just to indicate when there is an anterior cord syndrome, this is how you would demarcate, and the posterior cord syndrome is everything behind that line. All right. So now let's get to the point. So here, so we have finished complete cord syndrome, right? So that's pretty much a finished thing. Now comes to the anterior cord syndrome. So anterior cord syndrome is where you have the anterior aspect, which is the anterior 2/3 of the spinal cord that is affected, probably due to some kind of a anterior spinal artery infarction or something like that. So now these tracks or this region which had mark is now affected. So how are you going to? You're just going to read off. You're just going to tell the features that are affected and what is intact and what you expect. So, and it's always going to be motor and sensory and some clinical findings. So now think about the motor, right? So when you look at the lining, you can see that I have written, and also there's an arrangement when it comes to the corticospinal tract. Because in the diagram you can see I have drawn CTLS. It means cervical, thoracic, lumbar, and sacral. So what this means is much more medially or in the inside you have the cervical region, myotomes. So you will see more cervical presentations if it's much more inside. But anyway, in the anterior cord syndrome, you're going to have almost the entire thing affected. So what are you going to see? You're going to see upper limb and lower limb weakness, bilateral upper limb, lower limb weakness. So this is one of the present motor signs. Come to the sensory. Sensory, you can see that the dorsal column is preserved. So what you can say? The vibration, proprioception, fine touch, everything is preserved. While in contrast, you can see the spinal thalamic tracts are affected. So you simply say that pain, temperature, those sensations are affected. It's as simple as that. And then again, as I had said, all upper motor neuron below the level. So some maybe lower motor neuron at the level, but anyway, upper motor neuron below the level. So this is anterior cord syndrome, very simple, straightforward. Similarly, come to the posterior cord syndrome. Posterior cord syndrome is posterior spinal artery. You can tell something like that, and then you can see that area I told you that the one behind that line is going to be the one that is affected. So the dorsal columns are mainly affected. So your what is that? Fine touch, vibration, proprioception. These are affected while the pain, temperature, these things are preserved, and motor wise, there's no motor real involvement there, so motor is intact. Right? There's no upper limb, lower limb weakness. So those things are fine. So now come to the central cord syndrome. Central cord syndrome is just a region, a center, I didn't remark it that, but it's just a central region, right? That is, somewhere inside. So just imagine, there's the spinal cord is there, and there's a circle that is around midway, with the midway radius on the inside. So now you can see that. Now this is something that is in the center, so it's affecting everything to some extent, but certain things are much more greatly affected, right? So now if you look at the corticospinal tract, because we're looking at motor first now, so we'll look like that. Corticospinal tract, you can see the innermost ones are affected, and at the start itself I already talked about the cervical, thoracic, lumbosacral. That's how it is going from medial to lateral, from inside to outside in the spinal cord, or medial to lateral, whatever you want to say. So now you will see that upper limb weakness is more common. So upper limb is more affected than the lower limb, right? So that is something you have to know. Then the temperature and all the other sensations, they are affected to different extents. They might say, it's an upper cape-like distribution of sensation. So that is one of the things you can say for sensory, and otherwise it is the similar thing. It's an upper motor neuron below the lesion. So we have finished anterior cord, posterior cord, and central cord. What is the next one? The Brown-Sequard. So Brown-Sequard is when the half of this is affected. So just look at the picture carefully and just imagine one half is affected, probably due to some kind of tumor, stab injury, whatever the cause. Now you are coming to this one, Brown-Sequard syndrome, right? So here what is happening is, now imagine one side is completely affected. I will talk about the tracts, and you have to understand that the spinal thalamic tract is the only thing that crosses. So meaning it's going to carry information from the opposite side, while the remaining are pretty much the same. So now, let's say, now there's let's say one side, let's say your right side is affected. No? Now you're going to ask me, am I looking from the bottom or looking from the top? So let's say one side is affected, right? So if one side is affected, now you're going to have what? Let's look at the motor. Motor is going to be that side weakness is going to be the ipsilateral motor weakness will be there. Upper limb and lower limb will be affected in that side. Now what about the pain and temperature? Pain and temperature, we know it's a crossing one, so contralateral. Right? So there's a contralateral. Pain and temperature is affected, while as again dorsal columns, ipsilateral dorsal columns are affected, so vibration, proprioception, fine touch of the same side is affected. So since we have now finished also the Brown-Sequard, it's time to go for the conus medullaris as well as the cauda equina. Now these two things are always, they talk about this very commonly, and rightfully for the right reason, because they pretty much have almost the same name, and sometimes can be confused one for the other. So that's a very good way to test things out. But let's come to conus medullaris. So conus medullaris basically targets the end of the spinal cord, and for this to understand this one, you have to understand that the spinal cord ends at L1, L2. So the lesion is at the L1 vertebral level. This can be again some kind of fracture at that point, or it can be anything at that level. Right. So now this is when the spinal cord ends. So you're going to get something like, you're going to have some now because this is the end, you can't really correlate the diagram before this one. So this one, what you're going to do is you're going to think about the features, the important features that you need to keep in mind. Now if for an example, what we'll say is, in the motor you will see symmetrical lower limb weakness. And now if you're coming to the the sensory, or what is this, you will see early bladder sensation loss. right? Early spinster loss. And this is more of a low motor neuron. I mean, it's actually mixed. If you're looking at conus medullaris, it is mixed, upper motor neuron and lower motor neuron, right? Upper motor neuron, lower motor neuron. It's not lower motor neuron. And sensory, I forgot to mention, it's also saddle anesthesia. So again, motor is bilateral lower limb weakness, saddle anesthesia. You will see sphincter involvement, early sphincter involvement, and as far as is upper motor neuron or lower motor neuron, it's going to be both. Right, so we came all the way from top bottom, right? We talked about how everything below the spinal level being lower motor, upper motor neuron, and this one is a combination of both, right at the end. Now this is now why we're going to do is we're going to contrast this to the cauda equina syndrome, which is again an emergency, right? This is due to a large vertebral displacement. So you can see from a large vertebral displacing and compressing the room. So what you get here also, you get low limb weakness that is not symmetrical, late bladder involvement, but you will see as saddle anesthesia too, and in this case it's completely lower motor neuron. So now you might ask me then, what is this upper motor neuron, lower motor neuron? I have another video on that for neurological examination, but just to correlate it here, it's here and there itself, it's better to know that you have to look at tone power reflex. Everything is increased when it comes to an upper motor lesion, and it's decreased on the lower motor lesion. Babinski is one of the signs you will see for upper motor neuron lesion. So those are some ways to just quickly. So I think that's all you need to know about the cord syndromes. So sometimes the posterior cord syndrome, you can remember that the neurosyphilis is also related to that. Then syringomyelosis, I believe it's an ARSAC, right, where it imitates central cord syndrome. So those are some of the things, and yeah.